Okay, so we ended off with the adrenal glands, which sit on top of the kidneys. We see another depiction of that here in the upper right corner. When we talk about glands, we're talking about the endocrine system, by the way, which is not really part of the urinary tract. This is what distinguishes an endocrine gland from anything else is that it secretes hormones directly into the bloodstream. So it's a completely different body system. But as you've seen before, as we discussed the liver, for instance, which is an accessory organ to the digestive tract, because the liver provides many functions for many organs, but it does support the GI tract amongst them. Adrenal glands don't really support other systems, but they are part of another system. They just happen to be located here. That's why we're covering it. Adeno is our term for gland, and we are going to learn a little bit about the endocrine system this semester. We will not be covering that chapter because we don't have time to do that. So when you get to physiology and anatomy, you'll be discovering the endocrine system. You will not have gotten much information from this class, but there were some words that will be significant, and adeno is going to be one of them, as in adenitis, inflammation of a gland. An adenoma is a tumor of a gland. Adenectomy, excision of a gland. And adenotome, an instrument for removing a gland. So notice how the accent changed from adenoma to adenotome. So that's just another form of a scalpel that might be used in this type of procedure. So that kind of covers all the endocrine system you're going to learn in this particular chapter. I know we've had adeno before when we talked about the hidradenitis and that sort of thing. So the inflammation of a sweat gland. So here it is again. Hopefully you'll remember it. And as I said, there's lots for you to learn about the endocrine system. We won't be covering it this semester, unfortunately. Our other combining form for kidney is nephro. And I will tell you right now that that nephro is going to be the most common term you're going to hear. And it states that here. So it's important to know. We're going to give you lots of terms with that. But before we move on, I want to just take a quick look at this drawing we have here. So you see on the left a kidney that has not been dissected, on the right one that has been dissected. You see the ascending vena cava, the descending aorta. And do know that that blood supply from the aorta gets shunt off into something called the renal arteries. And so as the blood descends right about the level of your belly button, maybe just a little bit above it, there are branches that reach out of the aorta and go into the kidneys. They shunt blood, in other words, they redirect blood into the kidneys so that the kidneys can filter out waste products. And that's how we maintain homeostasis, as I mentioned before. So excess electrolytes, for instance, that Gatorade that you really didn't need, but you drank anyway, or that really, really salty lunch you had that was delicious, but had tons of salt. Well, more salt than your body needed, so you're going to urinate that salt out. And that's what the kidneys are doing when they're functioning. And of course, there's venous blood that then comes back out of there as well, because the kidney in and of itself needs its own blood supply. Point on this one, nephro is our combining form for kidney and the most common one. So nephrology is the study of kidneys. And here you see that depiction again. Here they also show the nephron. You can see the glomerulus here in the upper corner, the Bowman's capsule, right in here. So either word applies to it, glomerulus or Bowman's capsule, but that's where all that pressure happens. You see a little more intense capillary bed around the entire nephron as it descends. And to be quite honest, when you see the real depiction of it, that capillary bed is pretty intense. And once again, if you think about the alveoli in the lungs, these are very similar in structure and kind of in the way they function. They have different functions, but and for different systems, but in essence, they have a lot of similarities. And I bet you can guess what the next slide is going to be, because if we're talking about the specialty, we're always going to follow it up with a specialist. Nephrologist is a specialist in the study of the kidneys. They just study kidney disease, transplantation, and dialysis therapies. Dialysis, we will cover a little bit later, but dialysis is a process when the kidneys begin to fail. In kidney disease, there's a machine that can filter the blood short term for a patient. And when I say short term, it might be several years, but we'll get into that later. So nephrologists, these are the medical specialists that work on kidneys. So they're not going to look at the entire urinary tract. They're focused specifically on the kidney. So if you have a sort of a urinary tract problem and no one knows quite what it is, they're usually going to send you off to a urologist. They might take a closer look and say, oh, this is definitely a kidney issue. This is not a urinary tract issue. They'll refer you on to a nephrologist. And there's those words I promised you. A little bit of a data dump here, but hopefully it's not too bad. These are all using the combining form nephro. Nephralgia is pain in the kidney. Nephritis is inflammation of a kidney. Nephropathy is a disease of the kidney. Nephromegaly is enlargement of the kidney. Nephrosclerosis is a hardening of the kidney. And a nephroma is a kidney tumor. And we see a depiction of that up here in the right corner. So once again, tumor does not mean malignancy. It just means tumor, so there's a mass there. There is a common disorder called polycystic kidney disease, where multiple cysts will form on the outside of a kidney. Typically, it's a benign condition unless there's so many cysts that it affects kidney function. So that would be an example of tumors, small masses that would grow on the kidney, but they're benign. Of course, on the other side, there are malignancies of the kidney that happen as well. Just be aware that nephroma is a blanket term that covers both malignant and benign pathologies. And some more nephro terms for you. Nephroptosis. This is the prolapse or downward displacement of a kidney. So I know we talked about ptosis as a suffix before, early in the semester, and I said if you want to narrow it down to one word and make it easy for yourself, just say prolapse, and you've got it taken care of. So for nephroptosis, you could use that long explanation here. You could try to memorize that. If it's helpful, please do so. I would say if you just stated prolapse of a kidney, you're done, because we know a prolapse is a downward displacement. So I'll let you decide, but I think that's the easier way to go for me personally. Nephropexy would be a surgical fixation of the kidney. So if you had an optosis of the kidney, you're going to fixate it and try to put it back where it belongs. That's usually not usually, it's always a surgical process. They usually use some type of netting to place it back. Nephrectomy would be excision of a kidney. So if it's diseased, they can remove it. And you can remove one kidney and still have one functioning kidney and survive quite well. If you happen to lose both kidneys, then it's more of a problem. A nephrolith, is a kidney stone. Now, we saw gallstones in our last lecture, and those are nice, round, and smooth. They look like river rocks. Now we're looking at kidney stones, and they're compared with a match head, so it gives you an idea of how big they can be. And if you look at these are very hard, rigid calcifications with very sharp edges. If anyone has ever had a kidney stone, one of the major symptoms is something we call gross hematuria, which is an obvious amount of blood. Basically, the patient's urinating a combination, about a 50-50 combo of blood and urine. And it's quite distinct when you see it. It could be several pathologies causing it, but the most common would be a nephrolith or a kidney stone. Another part of the kidney that's really important to understand, and this is a great slide because it shows you some of these structures I referred to earlier. You see the major calyces, the minor calyces, the cortex, the medulla, the ureter. All these are really important structures. And we haven't got to the ureters yet, but we're about to in the next slide. For right now, though, I want you to know about something called the renal pelvis, and it's illustrated here in the diagram, and it points to the area that's considered the renal pelvis. This is the connection point between the kidney and the ureter. It's also a place where the urine that's being drained from the, let me get my mouse here. So from around in this area right in here through all of this area is just full of nephrons, and they're all forcing water and toxins and electrolytes out, and they go through these collecting ducts, and we have the minor calyces where the collecting ducts start, and then we have the major calyces here. And so this is the collection point where urine that's being drained from the nephrons will collect, and then it will transfer to the renal pelvis. The rest of the story I'll finish in the next slide. So you could have pyelitis, that's inflammation of the renal pelvis. Pyeloplasty is a surgical repair of the renal pelvis. There might be a blockage there or some form of inflammation or calcification that has to be removed. Pyelotomy, incision of the renal pelvis, and pyelostomy, forming an opening in the renal pelvis. So if there were a major blockage in the renal pelvis area, they may have to form a new opening and put in something to drain urine from the kidney short term until they can fix the problem with the inflammation or the stone or whatever might be blocking that passage. Make no mistake about it, your kidneys have to have access to get rid of the toxins they need to get rid of. If that access is blocked and they somehow back up, it's going to cause major damage to the kidneys and could potentially be life-threatening. So, especially if it's in bilateral kidneys. So it's really important that the renal pelvis remains open. And the renal pelvis, as I just stated, connects to the ureter. You have two ureters in your body, one descending from each kidney. Uterectasis is dilation of the ureter. Uterostenosis is a narrowing of the ureter. Uterorrhaphy is a suture of the ureter. And a uterolith is a stone in the ureter. So I mentioned kidney stones before, nephroliths. Well, if a nephrolith should happen to descend from the kidney in direction of the bladder and it gets lodged in the ureter, now it's a uterolith. The symptoms are going to be the same. There's still going to be a lot of blood. There's still going to be a lot of pain. Once again, if you've ever had a kidney stone, they are extremely unpleasant. And they usually require a lot of pain meds to get it under control before we can work on trying to get rid of the stone. And once again, we talked about the extracorporeal lithotripsy in the last chapter, and that would be something that you could apply to a uterolith. That would be probably very effective in destroying it because the tissue is very thin around there. Also to note here, and just seeing this diagram reminds me of it, there are folks who have more than 2 kidneys. It's an anomaly, but it happens. I've seen pictures of it. I've never witnessed it myself, but I've seen x-rays of it where someone will have an accessory kidney in one side of the body or the other, and they'll have, and here's the other interesting anomaly, they may have only 2 kidneys, but one kidney will have 2 ureters. So all kinds of combinations are possible out there in biology and in human development. It's just a matter of how things develop in terms of what your situation is or any given patient's situation. And those ureters, as they descend, assuming we have 2, which is 90% of the population probably, some have 3, some may only have 1. At any rate, their end destination is the urinary bladder. So I want to point out here the term cysto can refer to any bladder. It doesn't necessarily mean urinary bladder. However, in this context, we're referring to it as a urinary bladder. You're seeing the location here in this diagram. There's the kidneys. You see the descending ureters. They connect posteriorly to the urinary bladder. Cystitis would be inflammation of the bladder. A cystostomy would be forming an opening into the bladder. So if there was a pathology that didn't allow you to empty your bladder, there's a way to get in and to remove fluids if needed. There's a few routes, actually. Cystoplasty is a surgical repair of the bladder. Cystography would be a suture of the bladder. A cystectomy would be excision of the bladder. And some more cysto words for you. Cystoptosis is a prolapse or downward displacement of the bladder. Cystopexy is fixation of the bladder. A cystocele is herniation of the bladder. A cystolith is a stone in the bladder. And yes, indeed, you can have a stone in the bladder. A cystolithotomy is incision of the bladder to remove a stone. I'd like to go back to the first word for just a moment because it correlates to this drawing up here in the corner. Once again, using the mouse. So I presume that you can see this. If not, you just have to look at that drawing in the upper right. You'll notice that this urinary bladder is misshapen. This is cystoptosis. This generally would happen to elderly patients, although it can happen to younger patients. This, I'm not meaning to move that around, but it's moving around anyway. Let's bring it back to where it was. So in this drawing, in this diagram here, we see this pouch sort of area down here. That should not be there. That is cystoptosis. That is a prolapse of a urinary bladder. Actually, the bladder should follow this line right here so that it can drain out of the body. In cystoptosis, what happens is a pocket develops, and that pocket will retain urine. And it's dangerous for the reason that pathogens can grow in there. And since it's never completely emptied, that can cause really severe bladder infections that could turn potentially septic. So, word to the wise here. If you're working in a general practice or in your personal life or in any context where someone, especially let's say over the age of 65, is having constant urinary tract infections and being treated with antibiotics and they don't seem to resolve, it should be considered that cystoptosis is a possibility. Ultrasound can determine whether that exists or not. I think it can be done with CT. We can do it in X-ray if we need to, but it's worth exploring. Frequent urinary tract infections are considered to be abnormal. High use of antibiotics can put the patient at risk for further worsening infections because the antibiotics lose their effectiveness. So something to take a look at. And of course, cystopexy, that very next word, would be something they would use to raise the floor of that bladder so it would drain appropriately. No more trapped urine, therefore getting rid of the pathogens. So that's really the point of that process. And a couple more cysto terms here. A cystography is a process of x-raying the bladder, and a cystogram is the x-ray. So in this case, we have the urinary bladder. A catheter is inserted. Barium is inserted into that, or contrast is inserted into that bladder, and then we can take radiological photographs, in other words, x-rays of it, and we might be able to find cystoptosis by doing that. Urinary stones, bladder stones, other sorts of pathologies can easily be seen, tumors as well. That's our time for now. I'll be back in